Hello all, myself Shanam BM, Assistant Professor, Cardiovascular Technology, Yenepoya School of Allied Health Science. The topic is Atrioventricular Nodal Reentrant Tachycardia. The specific learning objects. By the end of this session, you will be able to describe atrioventricular nodal reentrant tachycardia, explain the mechanism involved in AVNRT, classify and explain the ECG changes in different types of AVNRT, list out the symptoms associated with AVNRT, enumerate the treatment involved in AVNRT. So, introduction. Atrioventricular nodal reentrant tachycardia is the most common type of supraventricular tachycardia. It is caused by reentrant circuit within AV node, leading to rapid and regular heartbeats. Synonyms is also called as AV junctional reentrant tachycardia, reciprocal or reciprocating AV nodal reentrant tachycardia, junctional reciprocating tachycardia. Definition. Atrioventricular nodal reentrant tachycardia (AVNRT) is a regular supraventricular tachycardia that results from the formation of reentrant circuit confined to a AV node and perinodal atrial tissue. So here you can see the AV node, you see a reentrant circuit confined to the AV node. Prevalence. AVNRT accounts for 60 to 70% of all supraventricular tachycardia, more common in women compared with men. AVNRT can present at any age. So, anatomy and pathophysiology. Coats triangle. It is nothing but it is an anatomical area in the right atrium where the AV node is located that has fast and slow pathway. Here, the Coats triangle is bounded by the tricuspid valve ring and the tendon of Todaro, and which bracket the coronary sinus at the base of triangle. This is the coronary sinus at the base of triangle and are nearby forming the apex near the His bundle at the membranous septum. As an approximation, Coats triangle can be divided into third. The anterior third, which contains the AV node and the fast pathway. Posterior third is usually the site of the slow pathway. So the location. So the fast pathway is usually anteriorly situated along the septal portion of the tricuspid valve annulus, with the slow pathway situated posteriorly, which is close to the coronary sinus, as I've shown in the previous image. So this is the fast pathway. So this is the fast pathway located anteriorly towards the tricuspid valve annulus, whereas the slow pathway is located near to the coronary sinus. This is the coronary sinus and this is the slow pathway. The two pathways. The AVNRT is a type of reentrant SVT, that is supraventricular tachycardia, with two separate pathways. These two separate have two different electrophysiological properties and are both located within or around the AV node. The slow pathway has short refractory period, whereas the fast pathway has a longer refractory period. The shorter refractory period refers to when the heart cells recover faster, can respond to a new electrical signal more quickly. So, as I have told you, the slow pathway conducts slowly and has shorter refractory period, whereas the fast pathway conducts rapidly and has a longer refractory period. So, next is dual AV nodal pathways during the normal sinus rhythm. During normal sinus rhythm, AV conduction occurs as follows. The normal sinus beat enters the AV node, the impulse travels down both fast and slow pathway. Here what happens is the superior portion of the impulses, that is from the AV node, it travels down to the slow as well as in the fast pathway. The impulses travel down the fast pathway, reaches the His bundle, creating a refractive wake or refractory period. That means the cardiac cell is unable to initiate the another impulses for some duration of time. That means, as I've told you, the impulses will travel down from the superior portion of the AV node. It travels down to the slow pathway as well as in the fast pathway. Here the fast pathway is faster, so it reaches to His bundle, then to the Purkinje fibers, the ventricle starts contracting. the impulses from the slow pathway, that is the impulses travel down the slow pathway, is exhausted. When the area of final common pathway, it runs into the refractory wake of the impulse that had traveled down the fast pathway. That means, as I have already told, the fast pathway is already in the ventricle. That means from the atria to the AV node, from the fast pathway, his bundle Purkinje fibers ventricle contracts. At the same time, this fast pathway goes to the slow pathway, it collide and cancel each other. That means the slow pathway is exhausted, which is coming from the superior portion of the AV node. So it cancel each other. Now both the pathways are in the refractory period. So mechanism of AVNRT. So it has slow pathway and has a fast pathway. In slow pathway, it has shorter refractory period, whereas the fast pathway has a longer refractory period. As if it is ready to take in another impulses from the slow pathway, since it has a shorter pathway. The premature atrial impulses enters the slow pathway, but it blocks the fast pathway because the fast pathway is under the refractory period. The impulse is conducted antegrade through the slow pathway. The ventricles are activated synchronously. From the slow pathway, this impulses is conducted retrogradely through the fast pathway. The impulses activates retrogradely and re-enters the slow pathway. This is how the re-entrant circuit occurs in the AVNRT. Types of AVNRT. There are three types of AVNRT. The difference between them lies in the configuration of re-entrant circuit. Virtually all AVNRT cases are characterized by one fast and one slow pathway. The findings on ECG depends on which this pathway leads to impulses in antegrade direction, that is to the ventricle, and the retrograde directions to the atria. There are types of AVNRT. There are three types, that is typical AVNRT. It is also called as a slow fast AVNRT, that is 90% of all cases of AVNRT. Next we have atypical AVNRT, which is fast slow pathway, that is 10% of all cases of AVNRT. Next is very atypical AVNRT, that is slow, which is less than 1% of AVNRT. Next is typical AVNRT. As I've explained the mechanism of AVNRT, it is the same. Here what happens is, in typical, the pathway, the antegrade conduction is in the slow pathway, whereas retrograde conduction is in the fast pathway. Hence called it is a slow fast pathway. Here what happens is, the premature atrial impulses is blocked in the fast pathway. Since it has a longer refractory period, this premature impulses will allow the antegrade conduction in the slow pathway. After conductions to the slow pathway, to the His bundle and the ventricle, the impulses is conducted through the slow pathway. Before it leaves the AV node, the fast pathway has recovered. That means it is out of the refractory period. The impulses from the slow pathway, it goes to the fast pathway, such that the impulse may also travel via the fast pathway. The impulses start to circulate within the AV node, that is atrioventricular node, and the re-entrant circuit is established. The re-entrant circuit will emit the impulses up to the atria and down to the ventricle simultaneously, which is why the B wave will be hidden with the QRS complex. So this is antegrade direction conduction, this is retrograde conduction. So this is slow pathway and this is fast pathway. On ECG what happens is, because of this, most of the cases P wave is hidden in the QRS complex. That means the P wave is hidden. Next, in some of the cases you see a pseudo, in lead 2 you see a pseudo S, or in V1 pseudo R. That is, P wave is sometimes seen after the QRS complex. It will present itself as a pseudo S in lead 2 and pseudo R in lead 1. So this is pseudo S and pseudo R dash wave in AVNRT. So this is pseudo S wave. After Q wave you see a S wave. Actually it is a retrograde P wave. It is a retrograde P wave. In V1 you see a R dash wave. This is the R dash wave. that is nothing but the retrograde P wave. Next is a atypical AVNRT. As I've told you, it is a fast slow pathway. In atypical, the fast wave conducts impulses in the antegrade conduction, while the slow pathway conducts in the retrograde conduction. As you can see in the picture, the fast pathway conducts antegrade conduction, whereas in the slow pathway conducts in the retrograde conductions towards the atria. This is what I was telling about. The fast pathway is conducted antegrade conduction, whereas in the slow pathway conducts retrograde conduction. This is the mechanism of atypical AVNRT. On ECG, you see a P wave will be visible before the QRS complex. P wave will be retrograde in 2-3 AVF, that is in inferior leads, and positive in V1. So here you see a retrograde P wave. You see a retrograde P wave before the QRS complex. Mainly you see on 2-3 AVF and positive in V1. Very atypical AVNRT, that is slow pathway. In this case, both pathways are slow. The P wave occurs somewhere on the STT segment. Here on ECG you can see the STT segment. The P wave occurs on somewhere on the STT segment. Symptoms: palpitation, dizziness, dyspnea, chest pain, fatigue and syncope. Treatment in the emergency settings. Always attempt to terminate the AVNRT by applying the vagus stimulation. Valsalva maneuver, carotid massage. If the patient is a child, bringing ice cold water to the face. If the vagus stimulation is not successful, adenosine can be administered safely, starting at 5 mg intravenously. If adenosine is contraindicated, fails after 2 to 3 repeated administration, either verapamil or diltiazem, that is verapamil up to 5 to 10 mg intravenously, or diltiazem 0.25 mg per kg is used, which is intravenously. Almost 90% of cases of AVNRT will be terminated using this algorithm, or synchronized electrical cardioversion may be preferred over verapamil or diltiazem. Importantly, the electrical cardioversion is the first choice if there is a sign of hemodynamic compromises. 10 to 100 joule biphasic shock, that is synchronized, is usually adequate. Long-term treatment and prophylaxis. The patients with reoccurring episodes of AVNRT should be considered for long-term or prophylactic treatment with beta blocker, calcium channel blocker or digoxin. Or radiofrequency ablation gives the virtually all patients that are preferred to such interventions. Summary, that is atrioventricular nodal reentrant tachycardia is a common type of supraventricular tachycardia. It involves abnormal electrical circuits within the heart's AV node. This results in a rapid heart rate, often causes palpitation, dizziness and fainting. Diagnosis typically involves an electrocardiogram, that is ECG, sometimes may require electrophysiological studies. The treatment options include vagal maneuvers, medications like beta blocker or calcium channel blocker or catheter ablation for refractory cases. These are my reference. Thank you.